We begin the second section with the VSIR, meaning APS-CVIR. This section is moderated by myself, Hoàng Bình Lợi, and co-chair with Dr. Nguyễn Đình Luân from Gia Đình Hospital. And the first topic by Dr. Ji Han-won. He is a professor at the University Hospital and with which many journal publication for many advances in infusion chemotherapy. Today, he will present topic endovascular treatment of maturation failure in hemodialysis access. Sorry, I speak Vietnamese to my audience. Kính thưa quý thầy, quý đồng nghiệp, phiên thứ hai đó là cái hội điện quang can thiệp Việt Nam sẽ gặp hội điện quang can thiệp Á Châu Thái Bình Dương. Và cái đề tài đầu tiên do bác sĩ Ji Han-won sẽ trình bày về cái đề tài can thiệp nội mạch điều trị cầu nối lọc máu không trưởng thành. And now we honored to introduce Dr. Ji Han-won. Please present your topic.
I am Dr. Ji Han-won from Korea. I work for a university hospital in Suwon. Today, my talk is endovascular treatment of maturation failure in hemodialysis access. Failing to mature arteriovenous fistula, maturation failure defined as a surgically treated AVF that fails to properly grow to become usable for the purpose of hemodialysis in 8 to 12 weeks after its creation. The incidence is a little bit high, so 23 to 46%. Etiology of maturation failure are poor inflow, poor outflow, and too much outflow. It means many collateral competing veins. Causes of maturation failure are classified as poor native vessel and post-surgical derangement. Poor native vessels are related to suboptimal artery, less than 1.5 to 2 millimeter, or a vein 2 to 2.5 millimeter in diameter, and extensive arterial atherosclerosis and pre-existing venous stenosis or even venous occlusion, and presence of accessory veins. Post-surgical derangement are narrow arterial anastomosis, juxta-arterial anastomosis, stenosis, and venous stricture formation. Classic radiological finding of AV fistula maturation failure is tight anastomotic stenosis like this. The stenotic area is histologically a grayish neointimal hyperplasia. This is the frequency of specific derangement. Most frequent stenotic area is juxta-anastomotic stenosis. Venous stenosis and arterial anastomosis stenosis are also frequent stenotic area. This is our data of endovascular treatment of maturation failure. Our data shows similar result. Juxtaanastomotic vein stenosis is the most frequent failure, and arterial anastomosis and venous outflow. The percent collateral veins after angioplasty was 13.5%. Now I'll show you example case. This 47-year-old man had a left radiocephalic fistula. The fistula was failed to mature due to juxtaanastomotic venous stenosis. Initial fistulography also showed a thin collateral flow. After successful angioplasty using conventional balloon, sufficient venous blood flow was noted and the collateral drainage was disappeared. This is an example of arterial stenosis. Radiocephalic AV fistula was filled with backflow, all artery and palmar arch and distal radial artery. This backflow filled AV fistula, but the flow is very small. Weak thread was palpated. We select radial artery with full French Bernstein catheter. You can see the very small diameter radial artery and occlusion of distal radial artery. We dilated a radial artery with 4 mm balloon and arteriovenous anastomosis with 5 mm balloon. Completion fistulography shows very good result. There are some controversy in treatment of accessory veins. Tomel mentioned that lack of maturation was caused by underlying venous stenosis in 100%, and they advocated angioplasty in all immature fistula. In contrast, Fiaja et al. Argued that lack of maturation is commonly caused by accessory veins. In this picture, you can see multiple accessory veins. This is radial artery and cephalic vein. Embolization or ligation of accessory veins would augment flow within the intended outflow vein and thereby enable maturation. In this patient, before balloon dilatation, there are many the collateral veins. After balloon angioplasty, you can see a widely patent AV fistula and the collateral veins are disappeared after angioplasty. Next case, the patient has a radiocephalic fistula. Maturation failure due to juxtaanastomotic stenosis. In spite of successful angioplasty of juxtaanastomotic stenosis, large competitive veins were persistently seen and still was weak. We performed the core embolization of the lateral with filling of the competitive vein and this collateral vein. After that, final histography shows very good flow and strong thrill was palpable in this patient. According to this literature, they suggest diameter criteria for accessory vein obliteration. 6% or greater diameter of the main AV fistula and 50% diameter of AV fistula with at least one more accessory vein over 40% in diameter. 50% in diameter and divides into branches of the same size. Accessory vein likely to interfere with cannulation on physical examination. These are diametric criteria for treatment of accessory vein. Accessory veins, live or not, the role of accessory vein obliteration remains unclear still. Accessory vein as a sole cause of non-menstruation is infrequent. If the accessory vein still had significant downstream flow even after the stenosis was treated, it should be obliterated either by surgical ligation or by coembolization. Intervention is effective when AV fistula had side branches without coexisting stenosis, and the diameter decreased immediately further along in the flow path from the side branch. But ligation is cheaper than embolization. So now we don't do embolization. If necessary, the surgeon do surgical ligation of accessory veins. Both embolization and surgical ligation demonstrated similar result of maturation and long-term functionality. This is our result of endovascular treatment for maturation failure. Technical success was 94%. Clinical success was 86%. Complication rate is 6.3%. Two major complications are vein rupture, 1.4%, second minor complication, about 5%, or are puncture site hematoma. According to the literature, complication rates are similar. One article said rupture of weak venous wall is common, about 50% of patients, the majority of which can be managed with just prolonged balloon inflation, balloon tamponade. In another article, local hematoma formation occurred in about 15% of the patient. In most cases, the hematoma was self-limiting and was contained simply with application of local pressure. This is our result. Primary pretension rate at 6, 12, and 24 months was 84%, 70%, and 6%. Secondary patient rate is 97% at 6 months, 82% at 12 months, 82% at 24 months. Our result of endovascular treatment is similar with other reviewed data. Clinical success is very similar. Primary patency at 12 months and secondary patency at 12 months are better than reviewed data. Major complication rate is similar. By multivariate analysis using Cox proportional hazard model, patient age over 65-year-old and over 90% stenosis were the independent predictor for the primary patency rate. Stenosis over 90% was the only independent predictor for both the primary and secondary patency rate. This is transradiatory approach from my Korean colleagues. Transvenous access was not feasible because the draining vein was small. They inserted small sheaths, 4 French sheaths, into distal radial artery. Single sheath is sufficient to treat downstream, even multiple or completely occluded lesion. You can see multiple stenosis here and here. After balloon angioplasty, they use cutting balloon. You can see the improved multifocal stenosis. But this transradial approach has disadvantage. Small diameter of the radial artery limits the passage of the large balloon or the thrombectomy device for declotting of a large thrombus, and more complication rate than transvenous approach. Maturation failure has difficulty in accessing immature vein because they are thin and fragile. Hematoma formation has been reported to occur in as many as 50% of procedure in which immature vein has been accessed. So we prefer transjugular access. Advantages of transjugular access are avoid the difficulties in cannulating immature veins, avoid the risk of hematoma formation after sheath removal, can treat multiple lesions through a single access. Operator's hand can be kept outside the direct field of fluoroscopy. This is an example. We inserted 6 French sheaths into the internal jugular vein. We advanced 4 French catheter to radial artery and performed fistulography. You can see juxtaanastomotic stenosis after balloon angioplasty from the internal jugular vein. You can see the improved stenosis. This is another example. We approach through the internal jugular vein, transjugular access. We failed to find cephalic vein orifice. So we used 23 gauge scalp needle to get venography. This is 23 gauge scalp needle. This is less traumatic and easy to hemostasis. We puncture the forearm cephalic vein, and venography shows small cephalic vein, but basilic vein is widely patent. So we approach it to the basilic vein. So fistulography shows this artery and just anastomotic stenosis. This is the cephalic vein. We performed balloon angioplasty with a 6 millimeter balloon. After the balloon angioplasty, no residual collateral vein and widely patent the fistula. Series palpate after the angioplasty. We report our result in JVIR. In 90 patients, mean total procedure time is 36 minutes. Venography using a 23 gauge scalp needle was performed in 31%. The mean time to venography was about 12 minutes. This is another example of transjugular approach for brachiocephalic AV fistula. In this patient, we use scalp needle. We get the venography. Venography shows the juxtaanastomotic stenosis here. Under the load map image, we can find cephalic arch. So we negotiate the cephalic arch and the cephalic vein, and then we get the fistulography. You can see juxtaanastomotic stenosis here. We performed balloon angioplasty. After that completion, fistulography shows very good results from anastomosis to cephalic arch. This is the result of transjugular access. Transjugular access was successful in 92%, and 7 patients required additional standard or transarterial access. Technical and clinical success rate was 98.9% and 90.5% respectively. As a minor complication, venous rupture occurred during balloon inflation in 9 patients, 10%, and it was managed by balloon tamponade. This is an example of additional arterial access. Venography using a scalp needle demonstrated an extensive network of collateral outflow vein associated with the complete obliteration of the main outflow vein. There are too much collaterals. The guide wire could not be negotiated towards the anastomosis, so the brachial artery was accessed, and phalanges was placed. Load beam image acquired from the arterial side of the AV fistula demonstrated anastomosis and juxtaanastomotic segment of outflow vein. The obliteration of the cephalic vein. After passing the guide wire from the brachial access into the obliterated outflow vein, a through and through access was achieved between the transjugular and transarterial access, and angioplasty of the outflow vein was performed using 6 mm balloon catheter. The completion, the fistulography shows good outflow. This is the case of bilateral approach from transbrachial and transjugular simultaneously. This is the result of transjugular access. Primary patency rate at 3, 6, and 12 months were 84%, 67%, and 48%. Secondary patency rate at 6 and 18 months were 98% and 95%. Very good result. This patient has maturation failure of brachiocephalic vein fistula. Venography shows apocephalic vein was obliterated. This is small collateral vein. The fistula flow is drained into the basilic vein through the multiple 2 collateral veins. We select this collateral vein and dilate with 5 milliliter balloon. After that, fistula flow drain into the basilic vein through the dilated collateral vein. Still was palpate. Hemodynamic access was successful. This segment is enough for cannulation of hemodialysis. In my conclusion, endovascular treatment enhances fistula maturation. Once usable, DJB fistulas have good long-term assisted patency rate. Transjugular approach for the PTA of immature AV fistula is effective and safe. Using this technique, vascular damage of fistula's tract and hematoma formation at the access site can be avoided. Thank you for your attention.
Thank you very much for excellent productive lecture. Thank you very much, Professor Wong. We're gonna do the Q&A after on presentations. I would like to move to the next topic. Next topic is endovascular declotting of hemodialysis. Assess how I do it. Presented by Dr. Kirati Honsakun. Dr. Kirati Honsakun is one of the excellent IR in Thailand. He's young, active, and he's focused on dialysis and venous intervention. So presentations begins. Thank you.
Xin chào. Good morning, everybody. First of all, I would like to thank you, VSIR, for the invitations to join the wonderful conference. So for my topics today, I would like to talk about the endovascular declotting of hemodialysis access, how I do it. It is my disclosure. I would like to introduce a bit of my centers. My center is spin-off Songkhla University, that located in the southern part of Thailand. We are the university hospital and the biggest hospital in the southern part of Thailand. And we have a lot of cases of the dialysis. And we are the dialysis centers. Okay, let's move to the contents. For the thrombose of the vascular access, include the AVG and the AVF. The SAWA treatment include the surgical thrombectomy, that is the standard method. However, the endovascular techniques also now is the other standard options to treat these conditions, including the thromboaspirations, mechanical thrombectomy, pharmacological thrombolysis, or combinations. So I would like to focus on the mechanical thrombectomy and the pharmacological thrombolysis. And the concept of treatment using the endovascular. The first one is to remove the thrombus. You should clear the thrombus from the access first, and then treat the underlying stenosis by using the balloon, angioplasty, and evaluate for the need for the standings at the underlying stenosis. However, the contraindications to perform this procedure, including the contraindication of the thrombolytic duct, and the next is the effects of the thrombose AVG or the AVF, because maybe it's a high risk of the septic embolisms, and also the infect clot usually have the decided biofilm from the bacteria, and it it's quite hard to lysis by the thrombolytic duct. Another is the severe contrast reaction. However, you can use the anti-contrast, it's like the CO2 instead of the iodinated contrast media. And usually in my center, I use the multi-cycle infusion catheter, 4 or 5 frames embedded into the clot, and then you use the GPA mixed with the sterile waters and infused via the infusion catheters, and you can see the jet flow from the side hole of the catheter, and the jet hole can make the mechanical effects and also chemical effects to macellate and to lyse the clot inside the access. And you can insert both of sheet into the arterial and the venous limb of the grafts, and also you use the infusion catheter placing along the graft inside the kiss cord techniques, and use the pulse spray techniques for the lysis of the clot. This is the example case. This patient has the thrombus of the left brachial-axillary lipid graft, and it is the vascular sheath that insert for the proximal and distal, and then use the catheter infusions for pulse spray thrombolysis. You can see there's some residual clot, into the grafts, and also the underlying severe cirrhosis of the grafts and the venous anastomosis. And this after the procedures, after lysis and balloon angioplasty, you can see it's a good result of the physiograms. Another case is a thrombus of the left radiocephalic AVF. From data sound, you can see that the clot inside the AVF. We puncture in the proximal pattern of the cephalic vein and insert the teeth. Also, we perform the angiogram from the brachial artery to check the access. You can see is the line of the cephalic vein, but now it's occlusion. So but now it's has a thrombus inside. And we insert the infusion catheters and perform the thrombolysis. And after thrombolysis, you can see it's quite open up of the cephalic vein and still residual thrombus and underlying stenosis at the AV anastomosis. After that, we perform the balloon angioplasty to macellate the clot and treat the underlying stenosis. And this final results with the good and pattern of the access. Another case is the thrombus of the left brachiocephalic loop graft, and from the picture, the clot involved into the graft, and also you can see clot extend into the cephalic vein and cephalic arch. In this case, from the other side, you can see that the clot inside the lumen of the vessel, and in this case, due to the clot is very long, so and the extensive of the clot, we use the mechanical thrombectomy. In this case, we use angiojet for the remove the clot like this. It's a bit forward. The clot will be resist and removed from the angiojet catheter. And this angiograms after lysis the clot, after remove the clot by the mechanical thrombectomy is quite good. And for the cephalic veins, it also is pattern. However, we found that after this angiograms, we found the access still is a pulsatile, is no tube. So we find the other point that may be still stenosis. So we found in this point at near the cephalic arch, at the stenosis and some thrombus embedded here. So in this case, we decided to put the stent, and then after push the stent, the access is is fast refill, and also we can palpate the tubes. That means that it's the success of the procedure. Also, we check with the ultrasounds. It's a patent, no residual clot in the AVGs, and also this Doppler current ultrasound also is a good. And for the procedure, post-procedural evaluation after the angiogram should be, the final angiogram should be patent of the AVG and with the less than 30% of the residual stenosis, and also by the clinical should be palpate the tubes. And the patient usually normal first hemolysis after the procedure. And this is our data that compare between the surgical thrombectomy and thrombolysis. The vascular thrombolysis in the thrombosis graph for the procedural success is not significant between two procedures, and also the mean patency time also is not significant difference about the 6 months. And also for the primary patency in the 6 months and 12 months also is quite the same. It's not significant difference. However, from the meta-analysis and review that show the outcome of the AVG treatment with the endovascular compared with the surgical treatment at the 1 year's primary non-patency usually found most in the endovascular treatment. So for the meta-analysis conclude that is the 1 year primary patency is quite better than in the surgical thrombectomy group. Again, it's the same in the 2 year primary non-patency. Also, it is quite better in the non-surgical thrombectomy group than endovascular group. And the result of the thrombolysis of the AVF, this is also our results. Our center, the clinical success rate is around 85%. Technical success rate is around 85%, and the clinical success rate around 100%. And the patency rate, the primary patency rate is 6 months is around 70%, and also the 1 year around 60%. However, the many data show that the result of the surgical thrombectomy compare for the surgical thrombectomy and the endovascular treatment in the thrombus of the AV fistula. From our data that show the primary patency at 1 year is quite better than in the group of surgical thrombectomy compared with the endovascular group. And that for the complication, the major complication for the thrombolysis including maybe the non-target embolizations, it's like a symptomatic embolization into the arterial size, and the hematoma or the bleeding side, the effects maybe from the thrombolytic ducts, the vascular perforations, death, and symptomatic pulmonary embolism. However, the ratio or the evidence or incident is quite, it's not high, it's just lower. For the pulmonary embolisms, usually after we perform the procedure and thrombolysis, usually the clot maybe is like the microemboli to lock into the pulmonary embolism, and the patient maybe is subclinical condition, is no clinical of the PE on the subclinical PE, because that I show the clot is just the emboli that can be the internal autolysis. However, there are the quantitative reports about the patient developed cardiac arrest after perform the thrombectomy in the AVF, because the large clot may be locked into the main pulmonary artery that can found. For the conclusion, pharmacomechanical thrombolysis is the minimal invasive techniques and the effective, durable, and the safe procedures. And it can be is an alternative treatment for the thrombosed dialysis vascular access, including the AVG or the AVF. And also for the advanced techniques, like the mechanical thrombectomy and the equipments usually can be the enhance the outcome of the procedures. Thank you very much.
Thank you, Dr. Kerati, for the nice presentation for endovascular declosing hemodialysis. And we have two abroad speakers from Korean and Thailand. That's why we will make Q&A now. And after, we will move for the Vietnamese topic. Professor Ji Han Won, can you hear me?
Yes, yes.
Okay. Và bây giờ thì chúng ta chỉ có hai cái chuyên đề của cái người speaker nước ngoài, và vì vậy cho nên là chúng ta đặt câu hỏi cho hai cái giảng viên này trước, rồi sau đó chúng ta chuyển sang tiếng Việt. Bây giờ xin mời quý thầy các anh chị đặt câu hỏi.
Good afternoon, Professor Wong. I think now is on afternoon in Korea, right?
Yes, yes.
Okay. Your presentation is very excellent. So, but in your data that you show that rupture of the veins is very low, about like 10% comparing to the others. So I would like to ask you that you can share with us about the tips to during the procedures that make your data is very low for vein rupture.
As you know, fistula flow is so fast. So AV fistula intervention is totally different from arterial intervention. If sometimes we meet the vessel population, but if there is no stenosis of outflow vein, vessel rupture is easily controlled with just balloon tamponade because blood flow is so fast. So after 5 to 10 minutes, sorry, 3 to 5 minutes balloon tamponade, the most of vessel rupture is controlled.
Thank you. Câu hỏi của mình đặt ra là sorry, I would like to make translation to our Vietnamese audience. Câu hỏi được đặt ra cho ổng là làm thế nào mà ổng có cái tip, cái mẹo nào để mà có thể là giúp cho ổng trong cái quá trình là điều trị nông cái tĩnh mạch dẫn lưu á, là cái tỷ lệ của ổng cho thấy là cái tỷ lệ vỡ của tĩnh mạch mà ổng nông nó rất là thấp cỡ khoảng 10% so với là 15% của những cái tác giả khác. Thì ổng chia sẻ về cái chuyện mà ổng dùng cái bóng nông và nông từ từ, và đồng thời ổng có nông theo kiểu mà từng bước một. Sau đó rồi nếu mà trường hợp mà có vỡ thì ổng sẽ tiếp tục dùng cái bóng để chẹn để giữ nó cỡ khoảng tầm 3 đến 4 phút. Thì lúc đó nó có thể là nó giúp nó lành tốt hơn. Xin phép ở trường hoặc là các thính giả khác có ai có đặt câu hỏi cho Professor Wong và bác sĩ Kerati thì vui lòng gõ đưa tay hoặc là gõ vào bên trong. Xin mời bác sĩ Hiền. Xin mời bác sĩ Hiền đặt câu hỏi.
Thank you, the chair, Dr. Lund. I'm very happy to see you, Dr. Won and Dr. Kirti Hongsakus. The first one, I have 2 questions for Dr. Won. The first, in your presentation, if the vessel very small, like radial diameter less than 1.5 to 2 millimeters, and vein diameter from 2 to 3 millimeters. How did you deal with that situation? I mean, how maximum balloon PTA based on parent vessel we can use? And the second question is, you talking about you use coil or ligation for twist accessory fan, right? I have a several case. I use glue to sacrifice the accessory van. So how do you think about that? Yes, thank you. And the next question for Kerry Hongsakus. Thank you your presentation. Do you use head ultrasound like mechanical effect on declot the AV fistula thrombosis when we see the thrombo very limited on the focus of segments from 2 to 5 centimeters? Thank you. I would like to translate to Vietnamese for my audience. Thưa quý thầy với quý anh chị, thì em có đặt 2 câu hỏi cho giáo sư Won and một câu cho bác sĩ Hong Saku. Thì cái 2 câu hỏi của em cho Professor Won đó là, nếu mà trong trường hợp chúng ta thấy cái mạch máu động mạch và tĩnh mạch bộ có một cái thông nối động của mình rất là nhỏ, ví dụ như là động mạch quay mình chụp ra trên DSA khoảng tầm 1.5 đến 2 mm và tĩnh mạch nó khoảng tầm 2 đến 3 thôi, thì cái cách xử lý của ông như thế nào? Và một cái đường kính khẩu kín của cái balloon tối đa ông có thể sử dụng được trong trường hợp này như thế nào? Cái câu hỏi thứ hai em hỏi đó là, một số trường hợp thì là tôi sử dụng cái keo sinh học để mà sacrifice các tĩnh mạch phụ, và tôi thấy là kết quả nó rất là tốt. Tại vì coi ở Việt Nam thì nó tương đối là nó mắc tiền hơn so với keo, thì tôi muốn hỏi là cái phương pháp đó thì ông nghĩ như thế nào? Và cái câu hỏi tiếp theo mà tôi muốn dành cho bác sĩ Hong Saku đó là, thỉnh thoảng tôi cũng sử dụng cái phương pháp là sử dụng cái đầu siêu âm để mà như là một cái cơ chế cơ học để làm phá vỡ các huyết khối ở vị trí rất là ngắn. Nếu mà cái cầu nối đó nó có huyết khối ngắn ở vị trí từ 2 đến 5 cm đầu tiên, thì kinh nghiệm của bác sĩ Hong Saku này có từng làm như vậy không, và ông nghĩ như thế nào về cái phương pháp đó? Thank you, and please, Professor Won.
Okay, thank you, Dr. Hien, for your good question. First question is, I use gradual balloon dilatation for very small vessel. Just the diameter is 1.5 or 2 millimeter. We dilated this collateral vein with 3 and 5 millimeter balloon gradually. We prepare our report to publish it in article. Those kind of gradual dilatation of small collateral vein can be alternative route for AV fistula. As I told you before, the AV fistula flows so fast, so just gradual balloon dilatation and balloon temperature doesn't matter for in terms of vessel preparation. And second question, you use the glue for obliteration of collateral vein, Dr. Yen?
Yes, sir.
Yeah. In the past, we used some coil, but I think the microcatheter and coil and glue are so expensive. The surgical ligation is very simple procedure than we expected. So nowadays, the surgeon do the ligation with the collateral vein surgically. It's very simple and very cheap method. So I recommend that kind of procedure. Thank you.
Thank you.
Good morning. Thank you for the question, Dr. Hien. So for your question, you asked me about the e-cost, right?
No, it's not like because it's got very high price in Vietnam. So I use very conventional mechanical. We use head of ultrasound to massage, to like mechanical effect on the AV fistulas.
Okay. So you can use ultrasound massage for the first cut and the aspirate, and you use the the last ball catheter aspirate the clot that you must search. However, in some time, the clot that you found is not the fresh clot. I mean, the patient maybe go to the hospital. Maybe it's a 2 day or the 3 days. In my opinion, I usually use the aspiration clot first, and then I perform the thrombolysis by the RTPA. And in case that I show in the extensive clot, I think the thrombolysis with the CDT cannot affect enough, so I will use the mechanical thrombectomy. For your question, I think it can do, but I'm not sure it's not a good effective enough. That is my opinion.
Yeah, yes, I think so. But sometimes we need to recanalize rapidly, and after that we can use more than treatment with balloon and balloon PTA after that.
Yes. Yeah.
Yes.
Thank you for the question from Dr. Hiền, and thank you for your answers, Dr. Kerati. And I think that we are running out of time, so we gonna have one more question from Dr. Bỉnh. Dr. Bỉnh asked Professor Wong that which approach is your preferred is first approach, transvenous or transarterial? Do you often use high pressure balloon concast or cutting balloon to dilate severely stenotic lesion? Professor Wong, please.
I prefer a transjugular approach for treatment of immature AV fistula, and then we failed. We do transvenous approach. Transarterial approach is the last option. And in terms of high ultra pressure balloon, the concast, the frequency of ultra pressure balloon is 50% in cephalic arch and 30% in outflow vein. The cephalic arch region is so tight, so in those cases we prefer the ultra pressure balloon than the cutting balloon. Nowadays we don't use cutting balloon because the ultra pressure balloon, the RBP is up to 40 atm, so it's enough for a tight lesion.
Thank you very much. And
okay, thank you for to both speaker confirm APS-CV IR. Very nice presentation and sharing your experience for arterial endovascular treatment in hemodialysis. We have many cases, and your share very important. Thank you one more time for your vote in the cooperation, and welcome the next time if we have a open for the meeting for VSIR. Thank you. Yeah.
Thank you.
Thank you very much.
Thank you so much.
And the next topic will be in Vietnamese, and thanks for your to both speaker. Và bây giờ thì chúng ta đã xong cái phần tiếng Anh và chuyển sang cái phần tiếng Việt, và tôi có ý định làm như thế để cho hai speaker nước ngoài họ rất là thoải mái. Và bây giờ tiếng Việt thì xin mời cái chủ đề tiếp theo là can thiệp đường mật qua da. Xin mời tiến sĩ Nguyễn Thái Bình. Xin mời.
Dạ, kính thưa các thầy, kính thưa các quý vị đồng nghiệp. Sau đây thì tôi xin thay mặt nhóm nghiên cứu đến từ Trung tâm Chẩn đoán hình ảnh và can thiệp điện quang